Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia.
Welcome to the Distance is No Obstacle podcast, and I'm Dr Olga Ward. I'm a wheat belt GP and I am not a GP obstetrician. I'm therefore very grateful to be joined today by Dr Penny Wilson and Dr Verelle Rooke, who are both rural GP obstetricians, to just give us a bit of a hand discussing antenatal care in 2025. I've been doing a lot of shared antenatal care over the years, and I'm actually finding some of the new guidelines a little bit confusing, and I'm not quite sure what's changed and what happens. So I would be really grateful if they could run me through a few bits and pieces. So welcome to the program, Penny and Verelle.
Thank you so much. Good to be here.
Great. And Verelle, you work in Augusta and Margaret River, and Penny, where are you?
I work in Perth and do obstetric locums to Broome.
Fabulous. We would love to see you in Narrogin sometime as well. Should you
ever
maybe
wish see you there someday.
There, that would be great. So tell me, what's really essential for antenatal care in a GP practice or a town where there actually isn't an obstetric service, which I have to say is a considerable amount of the wheat belt? How do you get started?
I'll go first. Look, I guess I believe that the focus on preconception care is really essential. So I often inquire with women who are of childbearing age what their plan is, and start having that conversation, because there's a lot of things to pay attention to even prior to pregnancy, such as the past history, medications and vaccinations and many of those things. I think if you're a GP, just general lifestyle habits, advice, checking diet, checking cycle regularity, and all that kind of stuff is really essential. So I start early and start there. And they do some preconception bloods if they're thinking that there's going to be a 6 months sort of leading time, and talk to them about taking folate beforehand, quitting alcohol, smoking, all those kinds of risk factors that we know impact really early on in pregnancy, even prior to conception.
Yep. What about you, Penny?
Yeah, I think it's essential for GPs to have an understanding of what is normal and abnormal in pregnancy, so they can identify when things are varying from the expected course, and escalate as appropriate, particularly if you don't have that service at hand in town. You need to know kind of when the referral is indicated. And I think GPs generally, not just in rural areas and not just in shared care, do really own the first trimester and the preconception space. So being really comfortable with what to do in the first trimester, I think, is crucial for all GPs.
Fabulous. And Verelle, you talked about vaccinations. Rubella vaccination, I guess if their antibodies aren't showing, and I know certainly there were a couple of years in Western Australia when the Rubella vax or the MMR just simply either wasn't properly stored or whatever and didn't work terribly well. So a lot of medical students seem to have had boosters. But which other vaccinations do you think about?
So rubella and varicella. So if there's no history of chickenpox, I usually check serology. It's important to be immune to varicella as well. And then, look, if it's flu season and women are trying for pregnancy, I will usually recommend a flu vax as well, or even if they're already, it's safe to give any time in pregnancy. So they're the main ones.
I think the other one to consider is COVID booster, because that is also safe and indicated in pregnancy. And it's kind of fallen off the radar for a lot of people, but there is still a bit of COVID around, which is, of course, riskier for pregnant women.
Sounds good. Are there any other things that you bring up, and are there any things that you bring up with the blokes? being as how sometimes even rural blokes do turn up for those pregnancy planning consults.
Not often, and I find many women ask, should my partner also have some kind of a check? And I always encourage them to, you know, do they have a GP? Can they make a consult to discuss their general health, their habits, their lifestyle, occupational things, maybe do some bloods, and obviously if there's any concern around conception not occurring, then, you know, to take it a little bit further. But yeah, I always encourage the men to come along to antenatal appointments, and certainly to have a checkup, and just get them in and having conversations around family support. Sometimes you have a lot of FIFO workers down here, and that's really important to know about how women will be supported throughout a pregnancy and when they have their baby. So yes, I always encourage the men to come along and have an appointment with their own GP as well, to talk about whooping cough boosters and other sorts of vaccinations as well.
There is a nice website about fertility called yourfertility.org.au, which I often will provide to couples who are trying to conceive. And it does have information for both partners, so the male and the female partner, which I think is a nice accessible resource for people. Sounds
good. The reason I'm just quietly being quiet here is because I'm writing these down so that we can put them in the footnotes for the podcast link. It just struck me, Verelle, you said occupational exposures. Are there any things that are particularly more rural specific, like chemical exposures or farm chemicals or mining assay labs, that we should warn women about? And are there any that we should warn men about?
So, yeah, I do like to know about occupation. I think there's a recent national resource that's become available talking about CMV infection in early pregnancy, even preconception, but in the first 14 weeks of pregnancy, recognising that CMV infection in the first trimester is responsible for quite a few thousand cases of congenital CMV with deafness, cerebral palsy, epilepsy, those kinds of problems. So women that work in childcare that have toddlers at home, counselling them and their partners around, I think it's the hand hygiene, not sharing eating utensils, washing hands after nappies and tissues and snotty noses and things like that that's recently sort of come out. So it's nice to know if women are working or working with children or have toddlers at home. I guess toxoplasmosis if they're sort of exposed to that in their work. Otherwise, it's general. Yeah, so sometimes chemical. Women sometimes working in mines are worried about certain exposures. I think it's just good to inquire and address any specific concerns that they have.
Yeah. Anything to add, Penny?
Yeah, even sometimes not so much chemical or occupational exposures in the traditional sense, but sometimes it's about just the expectations of the workplace. So if people are doing really long hours or have a lot of physical expectations for their work, sometimes that's worth talking about as well.
Yeah. And what about, I'm thinking more farmers, because I seem to have more farmers than miners at the moment, things like chook pens and sheepdogs and sheep. Anything that kind of comes to mind that I should be specifically mentioning to my patients?
Oh, I don't have anything to say about that. No experience there.
All right. Well, we'll go back to the super basic universal precautions and hand hygiene thing. So tell me about shared care. What's the difference in shared care with, say, if you're sharing with a specialist obstetrician or a midwife-led unit or with a GPO, which I think doesn't occur to a lot of people, but for which I'm mighty grateful, and so are my patients. What sort of information do you like in the referrals, and what can the patients expect?
Look, I mean, where I work, we have a fairly complex system now. So we did have an obstetric unit in Margaret River, which is now very much only midwife-led. So the majority of our women deliver up in Busselton or Bunbury. So as a GPO down here, I'm doing shared care with other GPOs in other towns, but also with the high-risk unit in Bunbury with a coastal obstetrician, but also with MGP who are local in Margaret River and Augusta. So it's a little bit of a complex arrangement, and I like to manage my women all the way through pregnancy if I can, but many of my colleagues will refer to me as soon as they meet someone who's pregnant to manage the first trimester, because they don't feel comfortable with the complexity now of NIPTs and preeclampsia risk calculators and all that kind of stuff that's come in. So usually if I'm referring to the MGP service or actually the high-risk antenatal clinic, I will provide as much information as I can regarding their risk factors, previous pregnancies, their past medical history, medications, allergies, all of their antenatal screening tests, early scans, really just everything that I can. I think that it's really important to share the information, and I do fill out what I generally try and give them at least an orange book, which I may start filling out, that the MGP midwives may complete filling out, and that's obviously the handheld record. I think that's super important for women to have that and carry it to all their appointments, particularly if they are moving between towns for their care.
Yeah, I love that booklet. I just I find that a fair few of my patients get placenta brain and they leave it at home on the farm. What about the screening tests you were talking about? So can you have a quick chat about the preeclampsia screening test and the NIPT? And I realise that now we're also screening more often for syphilis through the various trimesters. Is that something for everyone or just for patients that we consider to be high risk?
Yeah, the syphilis screening is recommended for everyone. I think because doing individual-based risk assessment is kind of fraught with danger when it comes to judgment and assumptions. And because it is, so much more common than it previously was, and there's big outbreaks in places, so it is recommended for everyone to have syphilis screening during pregnancy.
Yeah.
I can also speak to the preeclampsia screening. So this is something that we're learning a little bit about as the years go on, and preeclampsia is such a common and problematic cause of morbidity in pregnancy. And traditionally, the way of screening for preeclampsia has been through risk-based assessment, so asking people for their history and their risk factors, which would indicate that they were at higher risk and therefore need prophylaxis with aspirin. And there is actually a guideline for preeclampsia screening, or preeclampsia generally, but including screening through SOMANS, and that's available online. We can put the link in the show notes as well. But that includes things like high risk factors like previous preeclampsia, chronic kidney disease, pre-existing chronic hypertension, type 1 or type 2 diabetes, autoimmune disease, or sort of softer risk factors if people have multiple risk factors like age over 40, obesity, nulliparity, IVF, etc. Whereas nowadays what we can actually do is add in some ultrasound screening as well to increase the sensitivity of the screening test. And that's through uterine artery pulsatility index, which not all ultrasound locations can do, but some can. And that does pick up extra risk or extra cases who are at high risk. And so it can be a little bit more nuanced into who we recommend to have aspirin for prevention.
Yeah. So how would you ask for that, and how would you, like I've never done an ultrasound specifically asking for that. Would an obstetric ultrasound automatically comment, or do I have to stick it on the request form, and will the patient have to go and, certainly for my patients, will the patient have to go an extra 200 Ks to get someone who can do that?
Yeah, so it's not automatically done. It does need to be specifically requested. It's done with the first trimester ultrasound, so either the nuchal translucency scan or the early anatomy scan if they've had their NIPT, so between 12 and 14 weeks. And not all ultrasound places will do it. So here in Perth, I think there's 3 or 4 clinics that'll do it, but your average kind of community radiology will not. So it's not going to be accessible for everyone because those ultrasound locations tend to have a higher gap fee as well. But it is an option for people, and hopefully it will become more widespread as the utility of it is realised.
So
we just started doing it in the southwest. So our main radiology providers are now doing the uterine artery Dopplers and the placental growth factor blood test, which is a test that people pay for, and the cost varies between $50 and $100 in our local labs. And then the risk calculator, which is the fetalmedicine.org calculator. And it's a little bit of I've done it a few times, a little bit of a complex thing with some blood pressures that they need done on both arms. But it is coming back with a risk that is helping to determine really which women are at high risk of preeclampsia prior to 37 weeks of pregnancy. So it's a new thing for us down here, but I can see that it, we're really helpful to really pick up those women who are at risk for preterm labour from preeclampsia, particularly those under 37 weeks. So, yeah, and I hope it will be publicly funded at some point in the future. So I guess that's something to look forward to.
yeah, it sounds like it should be relatively easy to implement anywhere that can do a Doppler, but
Yeah, I think it's the technical skill of the sonographer, which is the rate limiting step. And just to clarify, in case it's confusing, the options are history, blood pressure, and ultrasound, plus or minus blood tests. So it can be done with or without biochemistry. And as Verelle said, the biochemistry does come with extra cost, and the biochemistry adds about 5% extra sensitivity. So from about 75% to 80%, I think, is the numbers.
well, hopefully, as you say, it'll become a little bit more widely available. How does the aspirin work in preeclampsia?
I don't totally know the mechanism of action, but we know that preeclampsia is related to placentation. Is related to placentation and abnormal placenta development. So aspirin seems to have some impact on the early placental development and therefore the risk of hypertensive disorders later. So the timing of aspirin is ideally before 12 weeks, but certainly before 16 weeks is when people should start taking it who do have that higher risk. And the dose is 100 to 150 milligrams per day. 150 milligrams is more effective, but it is more annoying because you have to take a 300 milligram aspirin tablet, break it in half, throw away one half, eat one half, and then do the same thing the next day. So if for some people, if that's too hard, they can take the 100 milligram tablet, but the 150 milligram tablet is more effective.
Why the heck would you throw away the other half? Can you not take it the next morning?
No, the aspirin loses its efficacy once it's out of its foil packet.
Oh, poo. All right. Well, it looks like it's carty for everybody then. Who do you talk to? Like, particularly if you're sharing care with a midwife-based unit. I mean, if I was sharing care with a GPO or a specialist obstetrician, I'd probably just get them on the phone. If you're sharing care with a midwife-based unit, whom do you call if something just doesn't look quite right?
I mean, even with a midwife-based unit, there's still oversight from an obstetric unit. So, for example, if we have women delivering locally in Margaret River with our MGP unit, we still have our coastal obstetrician in the unit up in Bunbury that we would talk to if we identified a problem. So, and that's who they would talk to. So if they were seeing a woman for a routine checkup and they were concerned about something, they might contact the local GPO in the town, in the community, or they would talk directly to, for example, Bunbury obstetric unit to get some guidance. So.
Fabulous. And can midwife...
there's a obstetrician gynecologist on call for every region in WA. So there's always somebody to call. And then, of course, tertiary centres are available for advice as well if needed.
Yeah. And can midwives prescribe... I mean, obviously they can recommend the 100 milligram or 150 milligram aspirin, but can they prescribe things?
It depends on the midwife. Some do have additional training that allows them to be midwife prescribers of things like vaccinations. But they can't prescribe the full gamut of medications that doctors can prescribe.
Yep. Okay. And so when you've got somebody who, say, might have essential hypertension or who has blood pressure that's just starting to kind of creep off into the realms of being hypertension, what's your first line? Like, I've always used labetalol, but I find the patients think it's a pain in the ass to take twice a day. I just find it a little more acceptable in terms of side effects. But what's your go-to?
Yeah, I think either labetalol or methyl-dopa, and I think they're both multiple dosings per day. So, yeah, you'd obviously do some bloods and screen for proteinuria and get them monitoring, hopefully perhaps at home, or and then start some medication at a low dose. But you may need to give them labetalol 2 or even 3 times a day.
Yeah.
Dose twice a day as well.
And this is one of those cases where preconception care is important, because if you have somebody who has chronic hypertension and who's on an ACE inhibitor, we know those are contraindicated in pregnancy. So switching them over preconception or early pregnancy to labetalol, methyl-dopa, or the other option is nifedipine, but it's harder to get. They'd be the safer options.
Super. Now, the other thing that I'm always putting my patients on is folic acid. I've had and I tend to run that a fairly long time, probably longer than's normally recommended preconception, because I like to get them into the habit of actually taking the jolly stuff. A few of my patients have recently turned up talking about their naturopathic appointment and their MTHFR gene and their folate processing. Is folinic acid that they always seem to get recommended, is that an equivalent substitute for folic acid?
Possibly, but we don't have the evidence. So this is, I think, an area where marketing has run well ahead of medical evidence, and they're doing a really, really good job of selling the stuff to patients who just want to do the best thing for their baby. There is biological plausibility why folinic acid would be effective, but folic acid, we have extremely large data sets that show it's very effective in reducing neural tube defects, and we don't have that data for folinic acid. So if patients do say that they want to take their folinic acid, I won't tell them to not take it, but I'll ask them to take folic acid as well.
Yeah, okay, that's sort of been my approach as well. I figure that it's useful to give them a safety net. Do you put them on 5 milligrams of folate and the folinic acid?
400 to 500 micrograms of folic acid is the standard dose. Unless they have high risk factors.
They have risk factors.
All right, and you don't count that particular gene as being a high risk factor, even though it supposedly says that they can't absorb folate or process folate properly?
I mean, a lot of people do have variations of their MTHFR gene, and we don't totally know the significance of it. If people are worried about it, then taking a higher dose of folic acid would be a reasonable option. But again, we just don't really know the right answer.
Mm-hmm. I guess it's pretty low toxicity and it's relatively cheap. So is there a problem with a big dose? Not as far as you know?
Not usually, for the length of time that they're taking it, I believe.
Sounds good. And then I'm sorry to keep harping on about preeclampsia, but to me that's the thing that we seem to most often kind of be hovering about in general practice and in shared care. How much proteinuria is too much, and how much weight gain is too much, or too little for that matter?
I think generally more than a trace of proteinuria is something that you would probably want to quantify with an albumin-creatinine ratio, but also combining that with other, like if their blood pressure's up a little bit, or they've got some headaches or some symptoms, or, you're just concerned perhaps for doing some bloods as well. But, yeah, I would always send off a urine for ACR with a more than one, with a 1+ of protein or more. But if they've got some edema and other symptoms, I'd be concerned and tracking it a bit more closely. And weight gain, I mean, between 8 and 15 kilos, I think, is the generally accepted normal weight gain, but it does vary a lot. I mean, I think above more than 20 kilos can be a bit excessive, and you worry about the women that aren't gaining weight at all. And obviously tracking baby's growth, which can be a consequence of excessive or underweight women.
Yeah. I've had a few... Penny. I've had a few women who've actually lost weight certainly in their first trimester from their nausea and vomiting. Penny, can you comment on that and also on whatever the other thing was that you were going to say?
Yeah, just about the proteinuria, one tip is that if patient has proteinuria that doesn't really make sense in the context of their other, their blood pressure and things, sometimes it can be contamination from leukorrhea, because people do have a lot of discharge in pregnancy, and it can contaminate the urine sample. So a clean catch sample can be helpful if they've got proteinuria that doesn't make sense. Mm-hmm. With regards to weight gain, the recommended target weight gain depends on your starting weight. So if you're a normal weight, then a weight gain of sort of up to 17, 18 kilos is acceptable. But if you start already overweight or obese, it's recommended to have a smaller weight gain. But having said that, I don't know how much control people have over their weight gain in pregnancy. Even if, you have a really good diet and exercise regime, some people just end up putting on more weight. So we can do what we can in terms of getting dietitians involved and exercise physiologists and things, but I try not to make it a source of shame for people.
Yeah, fair enough.
And you had another question as well, Olga, but now I've forgotten what it is, sorry.
And it can be tricky with weight gain, and we have bariatric limits in small sites where you've got a woman that starts at 95, and our bariatric limit in Margaret River was always 100 or maybe 105 if they're ambulating, and then they'd have to book for another hospital. So they'd get quite anxious about trying to stay under, but you didn't want them to do anything extreme so that they could have their baby in Margaret River. You wanted them to do what was healthy, and so that can be a little bit tricky in small sites as well that have bariatric limits.
Yeah. And what about the women who are vomiting?
Yeah, I think we need to be really proactive about this. And again, this is a GP specialty first trimester issue predominantly. So being really good at managing nausea and vomiting in first trimester is crucial. And I like to be very proactive about it. So asking patients how their nausea and vomiting is going, if they need help with medications. The first line treatment is a recommended over-the-counter vitamin B6 and doxylamine in combination. And then we can add in prescribed medication. So metoclopramide is usually what I would go to next. You can use other antihistamines as well, and then ondansetron can be helpful for people who have a bit more tricky vomiting, but it also is quite constipating, so beware of that as well.
Yeah. I'm always a bit wary of B6 after all the patients who develop peripheral neuropathies. Is the B6 doxylamine of such a dose that patients should be also worried about neuropathy? You would give them advice about if they did develop neuropathic symptoms, but the doses are fairly modest, so 12.5 milligrams morning and lunchtime, and then 25 milligrams at night is the recommended dose. So that shouldn't be sufficient over that sort of time frame to cause toxicity. But if they were taking supplements that, other supplements that had a lot of B6 in them, then that could be a risk. Yeah. Okay. So once we've got them finally through that first trimester, all those ultrasounds, just tell me, dating scan and a 12-week scan and a 20-week scan, is that like standard, and which of those is funded? As in, which of those is rebated? So
dating scans, I do bedside scanning, so I tend to do dating scans in my room, or I offer it, or offer them a referral to provider if they prefer, or if I feel that would be most clinically appropriate. I think it is nice to know, a lot of the time back in the past we didn't always do a dating scan if dates were certain, but I think with older women and risk of miscarriage, it's nicer to find out you've got a miscarriage at 8 or 9 weeks than at 12 when you go for your first formal scan. So then the 12 to 14 week scan is either part of the combined risk assessment first trimester screen for the trisomies, or is the early anatomy if you are doing an NIPT. So that gives you the opportunity to look at the spine, the nuchal fold, placental implantation, and now uterine artery Dopplers as well if you're doing those. So that's not rebated unless, I believe, women are over 37 and at risk of a fetal anomaly. Is that still the case, Penny? I think that's...
I don't know, to be honest.
Yeah, I think generally for women who are over 37, they will get a Medicare rebate, but for everyone else, it's not rebated. So that can be a costly scan. But the main scan really that's the most important one, is the 20-week, 19 to 22-week anatomy scan, because that really gives us the opportunity to check for major anatomical problems, plus location of placenta and growth. And so that's really the essential one if women are not keen. I do have women down here that are not keen on other ultrasounds and don't wish to do any Down syndrome screening, but the 20-week scan is essential. They can't book into a hospital down here without a 20-week scan. So,
yeah, the 20-week scan is also routinely in WA looking at cervical length now as well, which is a risk factor for preterm labour or preterm birth if it's short. So there are protocols in terms of managing a short cervix as well.
Sounds good. And then just anticipating, particularly if the patients are going out of their very small town to somewhere else for their ongoing antenatal care, they often still come into the general practice in their own town and have additional antenatal visits and most of their blood tests and things. Are we still on the 75-gram glucose challenge at 24 to 26 weeks? Has it changed in timing? Is there something else that we need to add in there along with antibodies and things?
So the protocol for diabetes screening used to be the 50-gram glucose challenge, which was 1 hour. And then the recommendations changed to the 75-gram glucose tolerance test. So that is the recommended test now. The best timing for that is 26 to 28 weeks, but 24 to 28 is okay. The other blood tests that you would do at that time would be syphilis screening, plus a blood count, iron test, and blood group and antibodies. And so then you can administer the anti-D if indicated.
Yep. And which syphilis test is recommended? Like, I've always done TPHA. Is that still your go-to?
Yeah, that's right.
Yep.
The other test, actually, which is important to mention prior to the 28-week mark, it can be done from 20 weeks, is there's now a rhesus NIPT for women who have a negative blood group. So it's to determine which women with a rhesus negative blood group actually require anti-D, so that you can give it to those women where it's detected that the baby has a positive blood group. So that's done through PathWest. I'm not sure if that's available in all areas of WA, but we give a referral for PathWest. It needs to be done between 20 and 32 weeks. I usually ask women to do it between 20 and 24 because obviously their first dose of anti-D would be given at 28 weeks if it shows that they've got a positive blood group baby on board. And it can be done with twins because if there's a positive, obviously one of the twins is positive. So that's coming, I guess, in the last 12 months, and that's really to determine which women absolutely need anti-D, which, is a blood product. And,
Fabulous. And if we do kind of turn up somebody, obviously, with something a bit more complicated, but not too complicated, like they've got impaired glucose tolerance, but not kind of roaringly diabetic, do they automatically then have to go to a regional centre to deliver, or can they still deliver in a smaller town? Like, how quickly do we need to bump them up the chain?
We don't really distinguish between impaired glucose tolerance and frank diabetes in pregnancy. You either have GDM or you don't.
Yeah.
We know it's a spectrum, but in terms of management, that's kind of what it is. I think it's going to depend on the specific unit and the local resources as to what level of medical complication in pregnancy they can manage. And certainly I know up in the north, in the Kimberley region, a lot of really small, really isolated communities do an extremely good job of managing diabetes in pregnancy, both type 1, type 2 and GDM, because it's so common, with input from the regional centre and the tertiary centre if necessary.
Mm-hmm. Yep. I guess if you're growing a 10-pound buffer, you might not want to deliver that in a
yeah. If you have diet-controlled GDM and the growth of the baby is normal, for us down in the southwest, then a low-risk unit like Busselton is still appropriate. But for women who end up on insulin, it's an automatic transfer of care to Bunbury, to the specialist unit. So we do have some parameters around that.
Yeah. And the other thing that seems to come back to me in single doctor towns is that the patients get sent back saying needs anti-D, but there's not always useful information on how to actually request anti-D. It's easy enough to give. What's the current protocol for giving it in terms of timing, and where do I get it?
The timing is for routine prophylaxis, a 625 unit dose at 28 weeks, 34 weeks, and plus or minus a dose after birth if the fetus is confirmed positive. And then as needed for sensitising events. So if they have trauma, if they have bleeding, something like that, then they can have an additional 625 unit dose after 12 weeks. Bleeding before 12 weeks, the dose is 250 units. There has been a recent change in the protocol where threatened miscarriage or bleeding without confirmed miscarriage and termination before 10 weeks is not an indication for anti-D, whereas it used to be. The idea being that a fetus of less than 10 weeks gestation has so little blood that it's unlikely to cause sensitisation. But as to where to get it, I'm not sure exactly where most people are going to...
Yeah, it's only available through hospitals. So for us, always a hospital-based product. So I write a med chart and people need to go around to the emergency department window at the local hospital. But, they don't stock it in Augusta, but they do have it in Margaret River. So I think it's a hospital-based product because it is a blood product. So I would imagine in most towns that would be where you would access it.
Yeah.
So we actually stock it in our GP clinic in Perth. We order it from the Red Cross, I'm pretty sure. But not every, that won't be accessible to everyone, particularly in remote areas.
Yeah.
So, I think hospital is going to be the most likely place for most people to get it.
Yeah. I think from memory, the last time I requested it, I asked the hospital to get it in, and the patient just went round and the nursing staff gave it. So what happens for you, rural, when the patients have kind of skimped on their antenatal care a bit, or they've turned up way too late in the pregnancy for some of the early screening tests? What do you actually do to kind of make up that gap if the first time you see them they're 29 weeks?
I think you do your best to fill in the gaps. If they haven't had their routine screening, you do it then. If they haven't had an ultrasound, you order an ultrasound to try and get some idea of anatomy and vague dates and placental location. But we would usually, again, not accept a woman that had perhaps no antenatal care prior to 29 weeks for a low-risk unit. We would need to link them up with an obstetric unit, higher risk.
Thereby making them even less likely to turn up.
Yes.
Because they have to travel.
Yeah, this is really common in the Kimberley, where I work a fair bit. People having limited antenatal care or late presentation, and the strategy is do as much as you can when you have them. So, we bring them into the ward, we do their glucose tolerance test, we do their ultrasound, we do their diabetic educator, their obstetric visit, their midwifery booking visit. We do absolutely everything that we can while we have them in the room, and then we don't know when we're going to see them again, so we just do what we can when we have them.
Sounds good. And then how do you manage to chase them up, particularly if you're not there all the time? How do you follow up if you inevitably get a abnormal result?
We rely on our community networks for that. So we have the Aboriginal Medical Service, the local GP clinics, the remote community health clinics, and there's just a sort of bush telegraph network of where is this patient, what are they doing, where have they gone, and oftentimes somebody can track them down or keep an eye out for them.
Sounds good. So hit them with everything.
It doesn't happen probably so much down here, but I also rely on the midwifery group practice midwives to try and stay in touch with women in the community who may not be presenting to medical appointments or to clinic appointments in Bunbury. We have had women also where local community members and reception staff at the clinic have said, I saw her down the beach the other day, and you've got a sort of a woman who's overdue, who's planning a VBAC after 2 sections, who lives quite remote out at Scott River or Malloy Island, and they're supposed to be waiting in Bunbury and they're not, and they're like, oh yeah, she was at the beach yesterday, she looked fine, and you're just kind of hoping that they get to the right place where they need to go at the time that they need to get there. So yeah,
and you hope that they don't select the beach as the place for them to do their VBAC. Oh dear. Yes, all right. That sounds like that's a work in progress for everybody, and thank God for the Bush Telegraph, hey? What about patients' mental health, which is something that can deteriorate during pregnancy, and certainly in closer-knit communities in a way that's better off. But I know with people living in remote mining communities and sometimes just on farms that there often isn't kind of a support network for them around because their family is interstate or down south, or they're just, what kind of supports are around, and how do you ask about how they're going mentally and how often without them feeling like you're labouring the point?
I think you ask all the time. Like we do in general practice, whenever we see patients, there's always a wellbeing and emotional health component to it. So ask frequently and often, and it's normalised. It's normalised. I think perinatal anxiety and depression is super, super common, and if we don't ask, we won't find out. But we do have a lot of options for support for people. So, of course, we have private psychologists, and many of whom have good perinatal expertise. There are also public options available. So there is a statewide support unit for severe mental illness through King Eddie's, and that is also available through telehealth, and that is either preconception or during pregnancy postnatal. So that's a really good resource for people who have severe depression, bipolar, psychosis, those more severe mental illnesses. But yeah, the sort of barn door anxiety and depression, very common, and does need to be really well supported within their community.
Yeah. Penny, is that kind of central stuff, is that all telehealth for more remote patients?
Yeah, it can be.
Sorry, Verelle.
I was just going to say, obviously the Edinburgh postnatal depression score is applied a couple of times during the pregnancy as well as postnatally, so that can be a way of assessing with an objective tool. But yeah, I always ask. There are some online resources that are helpful, so resources like the Panda website. There's also some online modules through platforms like, I think it's My Compass, and some of the other ones that have been developed by universities for 6 to 8 week self-help, sort of self-progressed modules, and many of those e-mental health platforms now have specific perinatal mental health modules, so women go on and they learn about anxiety or depression and the symptoms, how to manage it, with non-pharmacological tools, and obviously there's always the GP mental health plan to use to refer to counsellors or psychologists.
If you've got any. Do you find that patients actually engage with any of the apps and the online mental health things?
Some will.
Yeah. Sometimes it can be hard if they're busy when they have other children, or sometimes people don't feel like sitting online on a computer, but some do.
No. Yeah. No, and I guess number one thing, first they've got to have a computer, because they won't be wanting to do the online mental health thing in the community, like what used to be the telecentre. The community.
Yeah, they can often use, there are often apps for the phone as well. Lots of things are app-based as well.
Yeah. So just briefly, can you tell me about things like placenta previa and sort of more high-risk patients who really want to stay at home? When do we have to get them out of our community and into somewhere where there's a fighting chance that they might be able to pop out a live baby? I would love to speak about antidepressants in pregnancy. I've been very well supported by certainly my regional mental health unit in continuing patients who've previously been on an antidepressant, and it's been great to be able to kind of get their advice on what's safe and what doses are safe and or relatively safe. What's your take on that?
Yeah, so the bottom line with antidepressants in pregnancy is that if the mother needs it, they need it. And there are some, theoretical small risks, particularly in first trimester, of antidepressant medications, but it's hard to distinguish whether those risks are associated with the medication or whether they're associated with the underlying disease, because having uncontrolled anxiety and depression in pregnancy is also risky for the fetus. So I think we don't need to be scared of using pharmacotherapy if it's indicated. The most evidence base is around SSRIs and, to a lesser extent, SNRIs. We have the most experience with sertraline and escitalopram, so that would usually be what I would start somebody on if they are having antidepressants for the first time in pregnancy. But having said that, if they're already on something that works for them, it's okay to continue taking that, because mucking around with different doses and different medications in pregnancy can be really unsettling and unhelpful for people when they're in a rapid process of change.
Yeah, plus the nightmare of trying to wash something out. Imagine trying to wash out desvenlafaxine and put something else in just when you're struggling with it. Those patients who are struggling, I can at least use that as a flick-in thing to just ask them how things are at home. And I note that most of the antenatal guidelines are also asking us to talk about things like domestic violence at home or abuse at home, or indeed somewhere else in the patient's life. Do you have any kind of useful, sensitive how to introduce this topic? Easier with a patient who's got a mental health condition, because obviously you can just segue into it, but just asking cold somebody who comes off the street.
I usually lead into questions like that after inquiring about their mood and mental health and how things are going at home. Do they feel well supported by their partner? Do they feel safe at home? Has there been any previous history of any family domestic violence? And I do sometimes list the types of issues that women can have. So obviously physical safety, emotional safety, restrictions on movement, seeing friends, that kind of thing. But look, I know a lot of my patients quite well. I still inquire. I think you get a bit of a feeling sometimes, and sometimes women aren't keen to disclose. I mean, obviously it's trickier when the partner's in the room, and I know that the midwives do a very comprehensive family domestic violence screen that sometimes they note they couldn't do because the partner was there and it didn't feel appropriate. So it is a bit challenging. But yeah, inquiring about mental health is a good way to lead in. And I think, in fact, women are understanding and almost expect that they will be asked those questions these days, which is great.
Oh, that sounds good. Penny, any different thoughts, particularly for patients who are in a more remote community or a culturally diverse community?
Yeah, I think this is to some extent the advantage of being in small communities and having continuity of care through primary care, is that you sort of know often who's in those situations, particularly if you've got a good rapport with the patient over a long period of time and they feel safe to disclose. But often you know, because you work in ED and you see the ED presentations and you've seen the police come in, during various altercations and things. But again, you just ask sensitively and you ask frequently if it's safe to do so.
Yeah. And I guess the more doctors and the more different health professionals ask about that, the more it becomes normalised and in a way desensitised, and the patients don't feel like you're kind of over-scrutinising them. How do you get the partner out of the room if they're one of those controlling blokes that's just always hovering there?
Sometimes you just have to directly ask them to leave. Like, oh, we need to do a sensitive examination. Would you mind stepping out of the room?
Yep. That sounds, I
I
guess.
have on occasion asked a woman to wander off to do a urine sample in the toilet and then just popped out to get a glass of water and caught her on the coming out of the toilet, which is in a different part of the building, and had a little chat there. So sometimes you do need to be a little bit tactful.
Yeah. Good ruse. At least the blokes are unlikely to follow you into the ladies' loo. It's good. So again, we come back to that support thing, and I find that many of my patients who are higher risk because of a previa or because of their preeclampsia or whatever, but they are really, really reluctant to leave the community. You know, it'll be, oh, we're in the middle of harvest, or I have nobody to look after my 2 other toddlers. And so they stay beyond certainly my comfort level. What's the process for getting patients somewhere where if they require tertiary level care, they can get it without having to get someone on the 2-way from the paddock and then drive them 5 hours to get
I
into
think that's
town?
where you have your really good, robust counselling with an obstetric unit or your local sort of head of obstetrics in your area, where they fully inform the patient of the risks of remaining in their local community beyond what is safe. And that, I found that really helpful as a local GPO to have that backup of, and it's documented that the patient clearly understands that remaining on, East Augusta with a placenta previa beyond the recommended time is putting themselves and their baby at risk, and then the patient decides what they're doing. But there are logistical problems, and certainly I would imagine in the Kimberley much worse than for us down here. But for people to have to transplant a whole family, even up to Bunbury, an hour or two away, where there's no family or accommodation, or up to Perth, is really logistically difficult, and they're really often walking a very fine line. But I think it's all about informed consent and their understanding of, if something happens. Most of us have access to RFDS, but they don't always come in a timely manner because they can't. And so that's always really, I just explain to people that we may not be able to get you out in an ambulance or on a plane if things go pear-shaped. So this is why you really need to reconsider your plans for moving to a safer place.
I think something we do pretty well in the rural and remote communities is take a bit more of a holistic view of the family in their context. So, often it's about you don't want to come to Broome because you're in, whatever remote community, but what if we can get a support person to come with you, or what if we can find somebody to help look after that family member, or, what kind of social supports do you need to make this feasible? And, if you still don't come, then as Verelle says, it's informed consent and then emergency management as and when it happens.
I always think that every general practice really would do very well to have a full-time social worker engaged
100%.
to organise those kinds of things. With the tertiary hospitals, are there any little family units, a bit like the Ronald McDonald type house for kiddies with cancer? Is there anything for women who have to go on camp in Perth for anything up to 12 or 14 weeks?
There are accommodations available. I don't know off the top of my head what allowances they have for additional family members. I think support people can go. I don't know off the top of my head if kids can go as well. Do you know, Verelle?
No, and it was really tricky in COVID because they closed Agnes Walsh House at King Edward, and I had a patient who basically hired a camper van and stayed on the side of the road close to that hospital, waiting for her baby to come without her partner, another child. Nothing in Bunbury, and people think, well, it's only an hour and a half or 2 hours away, so we'll probably get there. So they sort of run the gauntlet a little bit. But I'm not sure about Fiona Stanley. I would imagine there must be something, surely. Is there the catchment, tertiary centre for the entire southern part of Western Australia. So.
Yeah, I always wonder whether or not that Medi-Hotel concept had been extended to particularly women with a couple of toddlers, and I always feel terribly sorry for the mums who do, say, have, twin 3-year-olds and a preview with their next one, and diddly squash in the way of support. And
I don't know the
how
PATS
they
scheme. Maybe I think with PATS there's some accommodation assistance. It's not a lot though.
No.
It doesn't cover the cost of an Airbnb for a whole family or whatever. But it is something.
No, and certainly not for 12 weeks. Okay, so I guess that's something that we still need to explore. So finally, is there some kind of GP antenatal care cheat sheet that talks about what you do at which visit and what item numbers can be attached to it, and what? Like I'd love a little kind of guideline thing, and I know that patient-held antenatal care booklet is pretty good. And like I said, most of my patients have placenta brain and they leave it at home. But what do you guys use, and what would you recommend for people who do very little antenatal care but who are trying to support their patients in their community?
King Edward have published a statewide maternity shared care guideline that does have, fairly easy to follow charts of what you do at each visit and what weeks you would see each person. And they do have information on things like trisomy screening and what to do about domestic violence screening and mental health and that sort of thing. So that is a good place to start.
Fabulous. Is that a downloadable thing or a printed thing?
Yeah, it's a PDF. You can just click on it and then download or print.
Sounds like something that might find itself into my resource files.
As for antenatal item numbers, Medicare item numbers, so the main one is the 16500. That's the antenatal care item number.
Yeah.
There is a 4001, which is for pregnancy-related counselling. That's a 20-minute minimum item number. That can be for a current pregnancy or a pregnancy that's happened in the previous 12 months. And then there is the 16591. I think that's the right number, 16591. That is the planning of pregnancy item number that can be charged once per pregnancy after 28 weeks and does have requirements for mental health and domestic violence, drug and alcohol screening. That cannot be co-billed with a specialist 16590 item number. So if they are having specialist private care, not specialist item number, but private specialist. So if they're seeing a private specialist, you cannot bill that item number because the specialist will bill their item number. And they'll be really cranky if you've already billed it and they don't get it. But if you're doing GP shared care with a public hospital, then you can bill that item number.
Okay.
Yeah, and same for us down here. If I'm a GPO in Margaret River, but my patient's seeing a GPO in Busselton to deliver there, I can't bill the 16591 because the GPO will bill the 16590. The 4001 as well, you have to do the special training. I'm not quite sure. I did it a while ago, but there's some little training module that you need to do to be able to access that 4001 item number. And interestingly, psychologists can also access that item number. So it can be billed 3 times per pregnancy episode, I think. And then there's the postnatal item number as well, which is the 16407, I think. And I do believe now, I've just discovered the other day, I think they're now tied to my Medicare registration. So that is also something we need to consider for our patients.
Oh gosh, so if my patients, say, went to a GPO for their shared care and then had a postnatal check with them, do we have to make sure that the patient goes to the GPO's My Medicare and then re-enroll them anyway?
That's what we're just trying to work out down here. So
very clumsy.
The other option is it's the same rebate as a 36, so you can just bill
it as a 36.
A long item number because they're both time-based, more than 20 minutes, and really the rebate is the same. So, yeah.
Fabulous. Look, I reckon we've covered everything I wanted to cover. Is there a final take-home message from either of you, or anything else that you think that is absolutely critical for the doctors to know about that I haven't brought up?
I would just love for GPs to feel confident managing pregnant patients, because they're not that scary. You just have to know a few little details. Most of the time it goes well and everything's uncomplicated, but just knowing what can go wrong and how to identify it is a pretty handy skill.
Super.
Yeah,
so
I think
agree.
it would be great if more GPs could manage. However, it does get a little bit complicated now with all of the genetic screening and early tests in the first trimester. I know some of my colleagues just feel much more comfortable referring to someone like me that does it all the time and has done it for a long time, has kept up with all of the changes. But it's also probably realistic that the first few visits are all very long and there's a lot of talking, and I think a lot of GPs just feel that it's not particularly well rewarded in terms of rebates, so that can be a bit of a barrier. But yeah,
Yes, I think the patients definitely feel that it's a completely insulting rebate, and hopefully some of the current campaigning will sort that out. Thank you so much for joining us today. That's a long podcast.